بسم الله الرحمن الرحيم. السلام عليكم جميعا. Good afternoon everyone. On behalf of the Continuous Medical Education Department at the King Khalid Eye Specialist Hospital and Research Center, we'd like to welcome all of you today to the KCASH Visiting Professor seminar titled Insights and Updates in Pediatric Ophthalmology. I'm sure it will be interesting to all of you. We are delighted to have you, Professor Ramesh, in this meeting, and we thank you for accepting our invitation, and we hope you enjoy your stay at Riyadh. This seminar is accredited with 5 CME, and you can scan the barcode for the program. I would like to thank the distinguished speaker in this seminar and for sharing their experience with us. And I would like to thank Dr. Semsa, the chair of the Pediatric Ophthalmology Division at the King Khalid Eye Specialist Hospital and Research Center, for his major contribution to this visiting Professor Week. And I will ask him to introduce our guest and moderate the seminar, and thank you.
Good afternoon, everyone. I would like to introduce Dr. Ramesh Kekunaya. He told me that don't spend much time introducing him. He told me that I'm the director of the Child Sight Institute and Center for Innovation and Technology in LB Prasad in Ahmedabad in India. I would just say that Ramesh is a wonderful professional, outstanding professional, very well known in the pediatric ophthalmology world, more than 150 published papers, more than 25 chapters of books related with ophthalmology. But the most important part is he's a kind person, a person with a good heart. And these virtues allow him to succeed as a person and as a pediatric ophthalmology. We are honored to have you here, Ramesh, and I don't want to spend more time, we want to enjoy your lectures. Go ahead.
Good afternoon, everyone. Thank you very much for having me here. I've been here for the last 3-4 days. It's been a wonderful experience interacting with many of you in the clinic and also in the operating room. And you have a beautiful setup, and you have fantastic cases coming up here. So I will start with my first lecture. It's on nystagmus. I know these are my financial disclosures, nothing related to nystagmus. But I know this is a lunchtime. You know, sometimes this can be there in nystagmus. There could be a slow phase and a correcting fast phase, you know. That's what typically you see. And you reach that, you'll see a fast phase, which is correcting. And sometimes it can go out of control. That's why we call it as opsoclonus and myoclonus. So there'll be a rapid movement and the rapid correction happens. So just to make sure that you are not sleeping, I just wanted to show this. So in terms of nystagmus, what really happens is it's about the fixation, right? You can see here in this it's here. This is where a congenital cataract patient looks at multiple things. And this is where sighted controls. They have to look here, it's pretty easy. So this is where we use a eye motility recording to really look at how the nystagmus work. So I'm not going to concentrate too much on the eye motility recording. I just want to touch upon some of the clinical aspects. And first of all, you need to know, this is the classification we should be using it. It's a classification of eye movement abnormalities and strabismus. CMOS, it's called. And if you see the classical congenital nystagmus and the motor nystagmus, what we use, it's all comes under one category here. Can you see? Infantile nystagmus syndrome. They all are together. And then the second part is fusional maldevelopmental nystagmus. So these are the two things what you really have to know. But the CMAS classification puts you on the international place where we all talk about similar thing. It's not that somebody can call it as a latent, somebody call it as a sensory, but it's best to put them on the use of words everybody uses. When you look at a nystagmus, just remember there is visual acuity of a person and visual acuity of an eye. These are two different things. In nystagmus, you are interested more in terms of visual acuity of that person. That's a visual function is more important than the eyes, because sometimes binocular vision can be better than uniocular vision in nystagmus. Look at central visual acuity, look at gaze angle acuity, and also never forget about near visual acuity. And in terms of what do you measure in nystagmus before making a diagnosis and before making a therapy, I have put into 3 table here. If you see here, in all the patients, look at the fast phase direction, look at saccades and pursuit movement, rule in or rule out abnormal head posture, and also periodic alternative nystagmus. Look at the movement intensity, see whether it's a conjugate movement or a disconjugate movement. See whether there is a strabismus or no. Look at what happens when you cover one eye. Is it a latent fusion maldevelopment nystagmus or convergence effects? And what is the effect of changing the gaze? And then this is the one all the residents must be knowing, right? During residency, what you have told is check the amplitude, check the frequency, and check the direction of the nystagmus. But if you want to give a therapy, I think for nystagmus, all of this, as a clinician who is taking care of nystagmus, you need to do all of those. When you do it, you know what's the plan for that particular patient. And infantile esotropia, these are the classic features. I'm not going into the details. You all know about it. They can have a decreased amplitude at null point. They can have a dampening of convergence on near vision. All that can be there. In terms of abnormal head posture, remember 3 T's: tip, turn, and tilt. They can have a right head tilt or a left head tilt. They can have a tip up or tip down. They can have a turn, right turn or a left turn. And they can have a alternate face turn. And one more thing to be added to this is they can have a multiplanar nystagmus. That is also seen in some of the patients. I will probably not run these videos because they tell how to evaluate an eye motility recording. I don't know what you have here, eye movement disorders video recording. We have the iLink 1000. It records almost everything, horizontal, vertical, individual eye. And they can have a chin down position. They can have 3 T's. This is the face turn to the right, to the left. This is the chin up position. This is the chin down position. This is the head tilt to the right. This is the head tilt to the left. And they can also have, as you can see in the middle picture, they can have a multiplanar abnormal head posture. So this is a little bit busy side. Whatever I'm going to tell, I have summarized everything here in terms of nystagmus surgery. I will give probably one case example for each of those. If it is nystagmus alone, as you can see here, you can do 4 muscle tenotomy and reattachment. We can look at the pros and cons of that. And if you have convergence dampening, you can do a bilateral medial rectus recession of 3 millimeter or a lateral rectus tenotomy and reattachment, you can always add to it. If there is a face turn, you know, Anderson, Kestenbaum Anderson, you can do it. Chin up, I usually do a vertical rectus muscle, but there are equal things. As you can see, Rich Hurtle, he promotes superior oblique tenectomy and inferior rectus recession. For chin down, inferior oblique tenotomy and superior rectus recession. Head tilt, I will show you a very, very simple way of doing it because this is pretty complicated. I will show an example how you can treat the head tilt. And with abnormal head posture, with strabismus also, we'll see. Look at this child. What does she have? Chin up, face turn, and she has a tilt. So many people ask me, what do you take care of in this particular patient first? I would probably look at what is the significant thing here. She has chin up and the face turn. These are the most important thing because don't try to do everything because sometimes when you cover one, the other things gets better. You can also check here because she got this chin up, we did inferior rectus recession. From here, she improved. With the Kestenbaum, we did it. Still, it's not perfect. And you can see she had a chin up position in spite of that. Sometimes I use this prisms in the clinic to see how much it is correcting. And I had to do a bilateral superior oblique tenectomy and see everything is corrected. In the first surgery, I did Kestenbaum and inferior rectus recession. That was not enough to correct the complete chin up. So then at the second procedure, I did the superior oblique tenectomy so that eye is not hypertropic. So this is the Hurtle's recommendation. He generally does the oblique and the yoke vertical muscles, both for chin up and chin down position. This is the chin up position. 4-year-old guy, parents brought him that he is not looking at iPad. He is always like this. It's 50 degrees. What do you do here? So this is his 9-gauge picture. He is absolutely fine. I did the inferior rectus recession, and because he is chin down, so I had to loosen, and resection of the superior rectus. You can see just with 2 muscles, he became all right. And he became all right so that when he is looking at the TV, this is preoperative. This is the way he used to see. Significant. And many people said nothing can be done for this. And you can imagine in nystagmus, in any of your childhood blindness, nystagmus never comes. They will talk about cornea, glaucoma, optic atrophy. But nystagmus per se, even if it is idiopathic, it's one of the significant cause for childhood visual impairment. You can do a lot for this patient, and you can see post-operatively, he's looking at the TV and he's playing with the other kids and he's fine. The last thing I wanted to correct is the head tilt. This is the patient, 3 patients you can see. The first patient has a right head tilt, second patient has left head tilt, and the third patient has a very large head tilt. What I do is very simple. I do a vertical transposition of the horizontal rectus muscles. If somebody has a right head tilt, I raise the right-sided muscles. You can see here, this is the cartoon showing. They have extorsion, but you need to create intorsion to correct them. For the right head tilt, I raise the right-sided muscle. What is the right-sided muscle? Right lateral rectus, I can upshift, and the left medial rectus, I downshift. And also, the right medial rectus, I downshift, and the left lateral rectus, I upshift. This is the simplest way to remember what you do. Right-sided head tilt, raise the right-sided muscle. Left side head tilt, raise the left-sided muscle. With this, you can see all of them. This patient has still some head tilt, but others are doing very well. But we can do some oblique muscle also in this case as a second procedure. And these are some of the eye motility recordings. I would not go into the details, but we do it right eye open, left eye open, and we can also see how the patient is tracking from point 1 to 2 to 5 to 3, 4. You can really track how they are moving. I showed in the initial picture. And this is available free. Any one of you, there are 9 operations for nystagmus. This is my friend, Dr. Rich Hurtle. She has written it about it very beautifully. But I just wanted to show some case examples. Multiplanar, everything we wanted to show. And this is available. If you want to read, this link is available free for everyone. Just open this. Top 10 tips for the management of nystagmus. It's a blog I have written to make it very simple, so that when you have a patient, because it's very rare, you can just refer this and then plan the surgery. Thank you very much. I'm happy to answer if there are any questions. Yeah. Thank you. Okay.
So you can keep going with it.
Okay, sure. So next, anyway, after nystagmus, I'm going to talk about surgical management of Duane syndrome. What, why, and where. Probably I'll talk about hidden secrets in the management of Duane syndrome. So Duane syndrome, I'm sure you see even exotropic Duane here, because in India now, in the last 1 decade, I see more exotropic Duane than esotropic Duane. So it's a combination, because in the West, it's mostly a esotropic Duane. But if you come more east, even esotropia is more common in the West. Intermittent exotropia is more common in East. So similar way, Duane syndrome also. These are my financial disclosures. Objectives, I just want to cover up the classification of Duane syndrome. When not to perform surgery. This is also is important. It's not always, to know about when to perform and what to perform. And I just want to cover up with some of the patient examples. What are the indications and options for surgical management? This is one of the largest series we had. This is published in 2012. The data collection happened in between 2002 to 2004. You can see very large number of type 1 with esotropia. And these are the sub-classification. You can see the type 2 and type 3 were very, very less. But as we move forward, we are seeing, I'll show that exotropia Duane patients as well. But in a Duane syndrome, I think all of these are important. Yesterday we saw one of the case. It looked like a Duane, but actually it was a band actually, that particular patient. First of all, look at what is the type. Esotropic, exotropic, orthotropic, and 5 to 10% of the Duane can have vertical deviation. See whether it's a unilateral or bilateral and the type. Amount of deviation for any surgical management, it's a given thing. But in Duane, look at some of these things which are specific. I always tell my fellows, when you reach a stage where you are managing a Duane, you have become a true strabismologist, because there are everything you need to plan. You need to know superior oblique surgery, you need to know inferior oblique, you need to know really how to think, because strabismologist is like a mathematician. You need to think a lot before you do, because one surgery does not fit everyone. So you need to really think. And to grade overshoot and retraction, we did not have anything. So this is what we published long ago in British Journal. we just look at it's like a ptosis measurement, Compare between the right and left. 10 millimeter on the adducted eye, no difference, no retraction. 13 and 11, probably grade 1. 8 and 11, because 10%, 20%, 30%. And you can see this is 50%, Yesterday we saw one case, there was a downshoot, but the downshoot happened here. It was not even adducting. So this way you can classify overshoots just by looking at the level of the pupil on both sides. You can see whether it's a type 1 or type 2. The overshoot is there or not. And looking at the limbus position, you can say whether it's overshoot grade 1, grade 2, grade 3. And the last picture, the cornea is disappearing. It's called pumpkin seed sign. When you look at the pumpkin seed, it just disappears. So these are the gradings which you need to know. And this everybody knows. Typical retraction, it's a grade 4 retraction as well as overshoot. Orthotopic Duane, don't do anything. You can see here in this picture, he has abduction limitation on both sides. But one thing, we studied this orthotropic Duane patients. They have poor convergence and a fusional vergence. In spite of good vision, we have seen that stereopsis is not as good as normal patient. But surgically, do not do anything. Because many people ask me whether we can do superior rectus transposition here to improve the abduction. It doesn't work. It makes it worse. Some of the patients, this is again with UCLA, I was there, we looked at some of the patient. Esotropic Duane sometimes can have hypermetropic error, and their face turn can be just corrected with a pair of glasses. This is nothing rocket science, but never underestimate the cyclorefraction and its thing. I always put a grading. Okay, whether it's ET, ortho, XT. You can see here. This is the DRS meter. I call it as Duane syndrome treatment meter. Where is the meter? Here. Okay, abduction limitation. Where is the overshoot? This is where I put it. I learned it from Stephen Kraft from Canada. He uses this Duane meter. Accordingly, you can look at. These are the most important things you need to consider. Let us go to some case examples. This is the patient. Upper panel shows the typical left face turn with Duane, with the -4 abduction limitation. My classical treatment for them, if the retraction and overshoot is not too much, I do a tiny dose of medial rectus recession, and then I do a monorectus transposition, that is superior rectus transposition to the lateral rectus. You can see the abduction has significantly improved, face turn has gone, and there is alignment. But only thing you need to remember, when you do a superior rectus transposition, on abduction there will be a little bit overshoot, which you need to explain to the patient. These are all other examples where I have done. If the face turn is small, if the esotropia is small, I do not do any kind of superior rectus transposition. I have an algorithm, I'll show it at the end, what is where I'll take a cutoff point to do all of this. In the upper patient, I did the transposition. You can see abduction improves by 1.5 units to 2 units when you do this superior rectus transposition. This is what we have studied. Comparison of augmented superior rectus transposition with medial rectus recession for surgical management. This is the graph which is important. This is superior rectus transposition. You can see 3.5 abduction limitation has improved to almost 2.75 or 2.25. In the medial rectus recession, it does not improve so much. We have really studied this to look at. Bilateral Duane, you can see 5 to 10% of them. In this patient, I've just done medial rectus recession on both sides, because you can see it's almost like a cross fixation. We did medial rectus recession. Look at this is post-op day 1. This is post-op 6 months period. And when there is a tight medial rectus, even if you do a medial rectus recession, it can improve abduction a little bit, you know. This is something you can see in Duane syndrome with this. So I just wanted to show one of the videos. This is, we are trying to do a force duction here. So let me see. Yeah. This is the medial rectus. And I was just telling, this is the Moody's I use, so that the rectangle, what I form, that's the area you can see. This is being, and also I hooked the superior rectus. This is the bar-base retractor I was telling. It really holds it very well. And this is the superior rectus recession, superior rectus detachment I am trying to do. And these are all the small hook, and this is where I'm looking at any adhesion between the superior oblique and the superior rectus. I can feel it and detach this. You don't have to really see, look at this. I'm trying to see, that's the superior oblique. In the morning there was a question, how do you really do it? I look at it, and then in this particular case, we are cutting it, and then that's a lateral rectus. And we need to clear it a little bit, because you need to really pass the suture, right? This is the transposition. In the morning, we did Nishida. Probably I do this one. This is almost 10 years ago. Now I don't do a tenotomy, and I don't transpose. And finally, what really matters is that 8 millimeter. The faster the change in the path of the superior rectus changes everything. It's not just the transposition. Dr. Rosenbaum has beautifully written about it. You know, this is where I use it. Now I don't detach this superior rectus, and I just hold it. And look at the incision size. I just close it with the glue. We don't have to. So when you do the surgery, please respect the tissue, don't pull it, and no too much of cotton tape, all that is not required. It makes surgical very easy and elegant. And this is the bilateral esotropic Duane, where we looked at, this is almost in 2012, that time we used to do. In a bilateral, I tried to do a bilateral medial rectus recession. And in some cases, we have also published, I do, if it is very significant, we do a superior rectus transposition and medial rectus. As in this series, we just had 5 cases, not more than that. And you can see, this is the preoperative abduction movement, and that's the postoperative abduction movement. And we do, the World Society of Pediatric Ophthalmology always does this webinar, okay? And I put this question to everybody around the world, and sure enough, 43% of the people do just medial rectus recession. Not bad, 30% of the people do medial rectus recession and superior rectus transposition. Why? They ask one question, how many of them develop vertical deviation? That's why you can see the VRT, very few people do it. And very few people do resection. Dr. Steve Kraft has a beautiful paper on this. And some people do other procedures. This just for your information, what is happening around the world, which procedure. This is what I was talking about. This is a paper we have published very recently. There is a high prevalence. It's completely changed. There is more exotropia. We are trying to figure out what has changed, but we do not have any answers at this point of time. We do have a very high prevalence, and 2 things are important. When you see a exotropic, it's seen more in males, and it's more in the right eye. This is something we have seen. It's more in males and in the right eye. Type 1 is more in the left eye and more in women. So This is something we have looked at. And sure enough, they will have a paradoxical head tilt. This is a clue for residents and the new fellows. When you see abduction limitation, as in this case, abduction limitation of the left eye, and the patient has exotropia, this has to be Duane unless proved otherwise. Because if somebody has abduction limitation, they have to be ortho because of orthotropic Duane, or most of the times they will be esotropic. When you see abduction limitation, whereas exotropia, that has to be exotropic Duane. So this is where we did the surgery, asymmetrical lateral rectus recession. She is doing very well, and we have looked at the publication of this. And generally, my preferred technique is for exotropic Duane. Depending upon the deviation, I'll come to the algorithm at the end, unilateral or bilateral lateral rectus recession. And when they have significant overshoot, we do this Y split. I think it's not playing. Okay. So Y split, all of you, I think I'm sure all of you know. I just wanted to show a very quick, sorry about the quality. I just split the muscle into two, almost 18 to 20 millimeter behind. And then what is the width of that Y? I just keep at the superior and inferior pole of that particular muscle. People say 20, 24, no grading is required. Keep it very simple. And this is the way I do this Y splitting. You can see both the Y split. This is the Barbie retractor. It's my favorite instrument. It makes your surgery very easy. So that's about it. You can see sometimes I do a superior rectus transposition to the LR insertion with periosteal fixation when the overshoot is very significant, as you can see in this case. And this is the post-operative picture. Still it's there, but it's much better than pre-operative picture. This is pre-op, that's post-op. And look at this person, very large exotropia. Look at this 9 gaze picture, -4 adduction and abduction. This is the type 3 bilateral, very rare to have. What option you have? Lateral rectus recession bilateral is what you will be thinking, but it may not be enough for this particular patient. We did periosteal fixation of both the lateral rectus. Again, I look at this, Duane meter, run this Duane meter, and then come to a conclusion. Here we did, because of all of this, you can see where it is, obviously exotropic, -4, not bad, retraction, overshoot, significant, adduction limitation also significant, because that is so tight there. You can see, this is the post-operative picture. He is doing very well, just by periosteal fixation, as Dr. Semsa explained yesterday. Very simple technique, don't make it complicated. And this gave him a very good correction. You can see, this is the Duane meter, pre and post-operative. I could improve. I could improve this to this. Oh, sorry. That really helps you to understand what impact you really made on this patient. When you talk to the patient, I'm not talking to them, hey, I can improve. Overall, I can improve 60%. But if you see abnormal head posture, I can improve almost 100%. If you talk about primary alignment, I can improve almost 100%. And all the time they come, hey, eye movement is same, doctor. I'll say, that cannot be improved. That's why I put this meter where we reached before and after. And the last case I wanted to share is vertical deviation. 5 to 10% of them can have a vertical deviation. You can do Y split. You can do just recession. You can do superior rectus recession. You can do inferior oblique recession or myectomy. These are the 3 options. Probably vertical Duane in vertical strabismus in Duane is a next 10 minutes talk. Probably I should skip it because it's a very subgroup of things. But I just wanted to show this case with exotropia with left hypertropia. You can see this is where we did a Y split and also lateral rectus recession. This is the preoperative picture. This is the postoperative. Again, I go to this webinar because I get a worldwide view what is happening around the world. Sure enough, many of the 102 people do lateral rectus recession and 39 people did asymmetrical. This is what I do. All of us do the most common. This is the surgery. But 4 people, they do periosteal. I also do it, but I look at the Duane meter and then. Preferred option for overshoot, sure enough, Y split is the most common thing. Last thing, there is something called Duane minus. They have all the features. Sometimes they may not have overshoot. Sometimes they may not have retraction. This is an entity. You can see this girl, she has a face turn. It behaves like type 2 or type 3, mostly type 3 Duane. But you can see in any of this picture, there is no retraction. It's full, almost. And this is not syxnopalsy. Just we did simple recession, everything improved for her. So this is the pre and post-op. This is why we collected few of the cases and we came up with, probably there are many cases even in this hospital, Duane minus, Duane sign retraction, sign limitation. This is a possible incomplete form of Duane retraction syndrome. So this is possible. Just I want you to, because many people misdiagnose them as intermittent exotropia. But why they should have a face turn in an intermittent? You have to think before you. It's not about, you might do lateral rectus recession. They may be corrected, but you need to know what's happening so that when we saw these patients, then we came up with research ideas. So someone was asking, how do you come up with the research ideas? It's from the patients. When you look at patients, ask 2 questions, what and why. When you ask this, you will definitely come up with these questions. This is upma. It's not ummali, what you make here. This is upma, is a favorite breakfast in India. There are 100 ways to make it. You can see some colors are different. Each mother makes it differently, and each of them are very tasty. But in Duane, you need to have those recipe to come up with what can be done best for your patient. Thank you very much, and this is the kind of algorithm. I can pass it on to you. You can take some pictures, unilateral, bilateral, esotropia, exotropia, and we have everything there. Thank you very much for your kind attention.
Thank you, Dr. Ramesh.
Yeah, just I wanted to explain a little bit about this. In our hospital, these are the 5 values we take. Patient first and always. Whatever you do, excellence, equity, with respect, irrespective of their financial status, treat them well, integrity and togetherness. With this, we are able to achieve many things. So just wanted to share that. Thank you very much. Yeah.
Thank you, Dr. Ramesh. Probably this is one of the most important parts of your visit, no? Your vision about the patients and how organize the healthcare with success, because you don't have resources, no? I mean,
Yeah,
so and
limited resources, yeah.
We were discussing yesterday that in the numbers of best hospitals in the world, what is the place that you're occupying now? 6 places?
Yeah, there is a Shimago evaluation from a Spanish independent company. We were very proud to say that they have put us on 6th position in the world, so it was very good news for us. We didn't know about it. We really didn't know about it.
So it's about that one, no? It's about the idea. I have one question. You use cautery when you were doing the recession of the transposition of the superior rectus before cutting the...
Yeah.
You usually use cautery because you put the clamp and then...
I always use cautery for a superior rectus muscle. I don't know your experience. When you operate and disinsert a vertical muscle, it always bleeds compared to horizontal. So I always cauterize the ciliary vessels at the insertion, not behind. So I take that. I don't know your experience. have you seen more? Because every patient, when I operate, the vertical rectus muscles bleeds a lot compared to horizontal. I don't do this in horizontal muscles.
I forgot to explain that Dr. Ramesh was training in UCLA, in Jules Stein Institute with Pediatric Ophthalmology, and also in England, he did, with Dr. Taylor, he did neuroophthalmology. So, and one question, could you summarize the indications of superior rectus transposition for the Duane, to refresh and to be clear, because we could have the tendency to overdo it or or abuse of this technique, and I think that we should be very precise about the indication.
Very precisely, I'll explain here. If somebody has a unilateral esotropia, less than 20 prism diopters and more than 20 prism diopters. If they have less than up till 15 prism diopters, I do either medial rectus recession alone or superior rectus alone. If it is more than 20 prism diopters, I do both. But when I do both, please bear in mind that I will not do 5 millimeter. I'll do 3.5 millimeter. If it is 35 prism diopters, I will do 5 millimeter recession and SRT. If it is 25, I'll do 3.5 and SRT. One thing we have learned over a period of time is do homeopathic dosage of the medial rectus. Don't do too much, because in the post-operative period, they can cause adduction limitation. So 20 is the cutoff for the single muscle or superior rectus transposition. And between 20 and 40, because sometimes Duane syndrome can come with 40 prisms of esotropia, I will do grading from 3.5 millimeter medial rectus recession to 5. But my SRT remains the same.
One more question regarding the Kestenbaum. You use your own formula for the Kestenbaum, or you use augmented, Marshall Park Plus, what is your approach, I mean, regarding the numbers with Kestenbaum?
Yeah, I have my own thing, but to make it very simple, up till 20 degrees, you have to do rule of 13, 8, 5 and 7, 6. 8, 5 and 7, 6. Up till 20 degrees of face turn. Just do 8 and 5 and 7 and 6. If it is 30%, 30 degrees, I do 20% augmentation. If it is 40 degrees, I do close to 40% augmentation. You have to do a lot, otherwise they will come back. And sometimes I have seen 60 degrees of face turn. I have done almost 50% augmentation. Sometimes 50% of 7 is how much? You have to do almost 10.5. So that's what I would use, 20%, 30%, 50%.
Thank you. Questions from the audience?
Thank you, Dr. Ramesh. I really enjoyed your lecture. I have a question about Duane syndrome. I always teach my fellows and residents that less is more in Duane syndrome.
Absolutely.
And this is a general rule that everybody should know. To achieve good results in Duane syndrome, you have to do the minimal, and you will get the best outcomes. Have you tried Nishida procedures for those patients?
Yeah, exactly. I was saying, now if after 2022, I don't disinsert the muscle, I always do the Nishida. You don't have to disinsert. Nishida, one suture, and then plus or minus medial rectus recession.
Do you do both superior and inferior, or just the superior?
Only superior.
Only superior.
Yeah. Unless it's a 6 nerve palsy or so, then I do both. Today we had a patient where there is a medial rectus palsy. We did both because it was -4. In Duane, always one muscle.
And where do you place the muscle?
I place 8 to 10 millimeter behind the insertion of the medial rectus. Of the lateral rectus. Yeah.
All right, thank you.
More questions for the audience? Ramesh?
Thank you, Dr. Ramesh, Professor Ramesh. It's very nice
Thank
presentation. But I have two questions. Did you notice more retinal detachment in patients with nystagmus or no? Does nystagmus induce RD in patient, pediatric age group, or even at an adult age?
I can't answer that question, but yes, before coming here, there was a retinal dystrophy patient, albinism patient with nystagmus. He had a shallow RD. But is it common? I don't think so compared to, maybe we do a lot of pediatric cataract. We see them very long term. Even nystagmus patients, we see them long term. And even the myopia patients, we see them long term. I see only one area where I see the maximum retinal detachment is ectopia lentis, maybe Marfan's or homocystinemia. If you follow them up for, I'm talking about 10 years.
No, just I'm asking about, because this jerky eye movement in nystagmus patient,
I
does
have
it
not
induce
seen.
RD or no?
I have not seen personally.
Okay.
But your thought process makes sense, but I haven't seen that because nystagmus patients with retinal dystrophy, they have a very moderate to high myopia most of the times, but I have not seen so frequently.
Okay, as you all you know, and the audience know, that the medial rectus recession and when the chances for slippage and loss is very common. Do you use a non-absorbable suture or just a vicryl suture? And suturing medial rectus recession and
Yeah, I still use absorbable suture, but I would be very, less is more, as Dr. Shata said, less is more. I would not change the suture. I would, only situation I use non-absorbable is probably a repeat recurrence of a slipped muscle, probably I'll use it. But I think there are 100 ways of treating a strabismus, probably it makes sense. But why it slips? Because if you don't pass nicely through the sclera, and these muscles are very tight. They are like thyroid muscle. Most of the times, when you do a forced duction test in Duane syndrome, they are very, very tight muscles. So there is a chance, but personally, I don't use non-absorbable.
okay, thank you.
I don't know how many of you use non-absorbable in a Duane medial rectus recession? Okay, yeah. Yeah, exactly, yes.
When I do large medial rectus recession
do
and
it.
when I just use
Sure.
non-absorbable.
Sure.
What?
Yes,
Yeah.
please.
Thank you, Dr. Ramesh, for the very nice lecture. I really like it. If a patient of Duane syndrome type 3 and with severe upshoot, and we already did a wall splitting of the rectus, and then after a few weeks, it recurred back, as if we did nothing. So what's your treatment options here in this case?
Yeah, residual overshoot, again I'll do an FDT. When you say you did Y split, did you combine it with the lateral rectus recession or just?
No. The patient was ortho and prime was only upshoot.
Okay. I would do probably a differential recession if they are really unhappy about it, because if they are orthotropic, I cannot do a periosteal fixation. I can only do a 3:2 ratio of recession of the lateral rectus and also medial rectus. How many patients I do it? I do it in a very selective patient where cosmos is an issue. So it can happen. I've done with quite a good success by doing a differential recession is one of the choice for them.
Inferior oblique recession here has any point, because I think to go for that, but I was afraid the patient will dip into hypertrophy after the surgery.
Yeah, if they have hypertropia, in spite of doing Y split, that's why I didn't touch upon we are just publishing a paper on vertical deviation in Duane syndrome. So if they have vertical deviation after Y split and the fundus shows excyclotorsion, probably there is a role of inferior oblique recession or myectomy. But if they don't have excyclotorsion, there is still hypertropia, probably I'll do a small superior rectus recession, which you saw in one of the patient I showed.
Thank you.
Not in a patient with orthotropic Duane.
I have not seen, I've done it very infrequently, but I recess 5, I split
Probably. Yeah. I always do the recession and Y-split, but not in orthotropic patient. It's always split them apart, and as he explained, that's what I do. Just split them in the same position.
Last question, Dr. Khan.
Thank you, Prof, for this nice lectures. My question regarding nystagmus. When do you use other options, non-surgical, like oral medications? And
Yeah.
what if the patient has no null point but does have nystagmus? What is your approach in that? And
Yeah.
last thing, also nystagmus, when do you do imaging for nystagmus?
Okay. Number one, what are the other options? Yes, I do use medical treatment like timolol, propranolol, and sometimes medicine in acquired nystagmus, especially with multiple sclerosis related, gabapentin, all these things, I use it. In a very small proportion of patients with periodic alternating nystagmus, I use baclofen with limited success. I can't say that it works beautifully. All in all, medical treatment, especially in an infantile nystagmus syndrome, doesn't work. There are many publications. Even tenotomy and reattachment, it does not improve the visual acuity. But we are doing the eye motility recording. There is something called NOF-X score. It's derived from the visual acuity and the fixation. The NOF-X score improves. That means the period which the eye is oscillating, the foveation time increases. Mostly theoretical, because most of the time they recur. So one word answer is nothing works in this patient. But if the patient is desperate, they come up with this paper, can you do it? I tell them I'll do it, but success rate is not guaranteed. Your second question is about the imaging. I had another talk on acquired nystagmus, but probably we don't have time. Whenever they have oscillopsia, whenever you see some kind of unusual acquired nature of the nystagmus, whenever the patient has vertical nystagmus, these are the three situations, I do 100% imaging. And also when they have a seesaw nystagmus, just to rule out chiasmal tumor or achiasmia, I do MRI. Otherwise, in congenital nystagmus, I do not do it. Having said that, I do an ERG, I do an OCT, I do an autofluorescence. I look at what is the etiology for nystagmus, for sure.
And what if the patient is ortho and has nystagmus?
I would not do anything for them. In that sense, unless they are desperate to get some treatment, I'll do a tenotomy and reattachment of all the horizontal rectus
You
muscles.
do recession?
No recession, just tenotomy, suture it back. So, tenotomy and leave it back. No, I'll cut the muscle, put the suture, put it back in the same position.
But what is the idea behind that?
Its idea is you are cutting the proprioception through the brain, and so that arc of, because there is a structure called neural integrator in the brain. You break the cycle so that the foveation time becomes better. It's mostly theoretical. I don't know around the world, if you ask whether it really works, people say it has got a placebo effect. But patients comes to you with desperation. They say, can you do it? I think Dr. Lingua, he does even cuts the muscle and leaves it. So I would not do that, but this is a safe procedure. I offer it to some of the patients. If I have 100 nystagmus patients with ortho, probably I do it in 5 or 6 patients. It's not very common procedure. I do it. Yeah, somebody was saying.
I was just saying that the results are temporary.
It can come back, absolutely. These proprioceptors can grow back, and then you might go back into the same position over a period of time. And sometimes it can have a placebo effect on the patients.
Let's have a break of 10 minutes. Thank you very much for this session. See you in 10 minutes, okay?
Okay. So welcome back. From the strabismus, we'll move on to the cataract surgery now. I'm going to share some of the cases, some of the unusual cases, and probably some of the tips in terms of evaluation. Because most of the times when people think pediatric cataract, it's not just surgical. I feel surgical is the very small part of pediatric cataract surgery, but the rest of the things are important. So these are my financial disclosures, nothing related to the cataract. When you look at a childhood cataract, all of these are different cases. It's not, it looks similar, but in terms of etiology and in terms of morphology, they all look different. In the MRI picture, you can see the size of the lens is different and the globe size is different. And this is where we look at our situation in India, unilateral and bilateral. Bilateral is mainly familial and infection. Unilateral, most of the times, it's because of ocular abnormality and trauma. And this is a must in every case of pediatric cataract surgery. Sometimes I feel surgery might take 15 minutes, but in terms of evaluation intraoperatively and postoperatively, it takes a lot of time. But when you evaluate pediatric cataract, just remember 3 F's. F number 1 is face, F number 2 is form, F number 3 is family. Family, form, and face. Look at every patient. You will rule out or rule in familial causes or genetic syndromes. Always remember 3 F's when you evaluate a case of this patient. Why? Look at this face. The first patient is a Lowy syndrome. Lowy syndrome is what? Oculocerebrorenal syndrome. They have a hypotonia, and when you look at their face, you can see the temporal atrophy. Even in a newborn child with cataract, you can see. And in terms of form, they have miosis, they have microphakia, they have microconia, they have peripapillary rough. That means it's Lowy syndrome. The last child, you can see the face. This is a typical Hallermann-Streiff syndrome. If you see once with that alopecia, big nose, and when you see a microconia with cardiac defect with the hearing aid, remember it could be rubella syndrome. When you see an inverted Y suture in the mother and the cataract in the child, it's usually Nance-Horan syndrome. These are all very typical things when you look at pediatric cataract. This is the cataracta pulverulenta. You can see this is a patient with spasticity and new onset seizure at 1 year. When you look at the MRI, you can see bilateral global pallidus. Diagnosis is unclear, and this could be a developmental cataract with metabolic disorder. And she was advised whole genome sequencing. And this child had this problem where there is a neurodegeneration. Why am I showing so rare cases? Because for a parent, you are the pediatric ophthalmologist who will take care. Maybe it's 1 in 1,000, maybe it's 1 in 10,000 patient. But for them, there is nowhere to go. You need to help them. And this is one of the patients you can see. Face, family, and form of cataract is very, very important. Again, this patient has partial optic atrophy, as you can see, with bilateral developmental cataract. This patient has something called Marinesco-Sjogren syndrome. You don't have to remember all this syndrome. There is a site in PubMed, OMIM, Online Mendelian Inheritance in Men. Obviously, it's not only men, it's for everybody, but the short form is only OMIM. Just put this components, you will get the syndrome name in most of the patient. And this is the developmental delay with microcornea, with the progressive optic atrophy. You can see the family. And this patient has this hypoplastic corpus callosum. And look at the child. Both of them have very similar features. Face, family, and form. Always look beyond the eyes. You will have an answer. This is anybody can guess this? When you see this whirl of hair here on the front, microcephaly, typical nose with the broad philtrum, this is very typical of rubella syndrome. You can even see in babies. Look at the lower middle picture. That is a 3-month baby. You can see a whirl of hair, very typical of congenital rubella syndrome. When you do cataract surgery, you see sometimes dog ears. Iris is coming from the side port. This is very typical. That means the ETCO2, end-tidal, because as a pediatric ophthalmologist, you should always work with the anesthesiologist. Always be friendly with them and talk to them what's happening. You need to know a little bit of that. Look at the ETCO2. Always it should be below 35. Otherwise, you think something is wrong, but actually the choroidal pressure leading to intravitreal pressure, you will see from the side port, the iris can come out. So always have one of the eye on the parameters, what the anesthetist use it. Just wanted to share this. This is one time I was doing the surgery in Orbis. Can I forward it? Okay. I'm not able to really forward it, but anyway, this is a 3D recording of a cataract. Just wanted to show, it's a long video actually. Okay, leave it, probably. One of the ways you do a capsulorhexis, just remember grip, grasp, re-grasp and inward pull. This is what is important. Just gripping is very important. And that has to be continuous, curvilinear, smooth, and well-centered. Can you see here? I always make one nick. It's like each of us has a way of doing, writing 0, right? Some people write 0 like this. Some people write like this. Whichever way you are convenient, that's where you make an incision here. First, make the grasp of that anterior capsule. Hold it, re-grasp, and then usually the size should be around 5.5. Once you reach there, it's beyond your pulling power. Re-grasp here, and then always make sure that you're pulling it inward. This is extremely important in pediatric cataract surgery. And once you have done that, this is for manual. I know there are automatic things available, but this is the way you should learn. Just remember, grip for anterior capsulotomy. When you have, there are many ways to do a capsulorhexis. Sometimes you can stain the anterior capsule with trypan blue. Sometimes in the second video, upper second video, I am just using the sheen of the capsulorhexis, the shine. With that, you can complete the rhexis. That's a typical case of posterior lenticonus. You can see that behind you can see a triangular or elliptical plaque there, opening there. And the last video is vitreorhexis. You can use the cutter, especially in cases of PFV, persistent fetal vasculature. Make 1 or 2 stabs on MER blade and then try to cut everything using this vitrector. You have to reduce the cut rate so that you can completely take out this. So sheen rhexis, stain rhexis, scissor rhexis and vitreorectis, these are all the options depending upon the form and the type of the cataracts you can use it. One thing I always do, This is the step I take a maximum time in pediatric cataract surgery. Capsular polishing, which is the under surface of the capsule, you have to go till the equator so that you always take out as many lens epithelial cells as possible, so that in the future the visual axis opacification is much more reduced. Otherwise you will have it. So go underneath this and try to really polish everything. This takes much more time, but be patient. This is, I think, it's an important thing. And in terms of size, if I'm putting an aphakia, if I'm making an aphakia, I keep the size similar. If I'm putting the lens in the patient, then the anterior capsular axis size will be 5.5, and I keep it 1 millimeter less. And you can do the manual capsule. Yesterday we were having a discussion. You can do a manual rhexis before implanting the lens. But I know in a teaching institute, for me, in any surgery, safety is the most important thing. It's not your skill or whatever way you can, but first and foremost thing is, how can I safely do this surgery? That's why you can see in the second video, even if you do the vitrorhexis after doing the capsulorhexis, it's equally good. Nothing to feel bad that, hey, I did with the vitrector. Absolutely no problem. Both gives a very, very good outcome. The lower one, the first one is the manual. That also, in my experience, the posterior capsulorhexis is much easier than anterior capsulorhexis because it does not tear much. It's just less thinner, but it does not really go away. So I'm happy to do vitrector rhexis after implanting the lens. As you can see in the second video, we are almost done with the vitrector there. Make sure that there is no residual vitreous in the place there. One thing I always use is peekaboo sign in pediatric cataract surgery. I use an air bubble or I adjust the microscope height. Always look at the optic disc and the posterior pole using this sign, because next day when the child is there 3 months or 2 months, they'll be crying. You have to talk to the parents whether the prognosis is good or bad, because you need to, with 30 seconds, you can look at the posterior pole very easily in this patient. So can you see? There is an air bubble. It's the cheapest technique. You don't say that, get me a sterile 20D or a headset. Anybody can do. Air is free. It's just that you have to use those 30 seconds. So it's called peekaboo technique. We have published this also. Use it in every patient rather than struggling on the post-operative day. You could do this. And sometimes I do this. I was talking to Dr. Sesma. He does a lot of capsular laser. I also do this Zepto pediatric cataract surgery where precision pulse technology you use. There is a handpiece, after making side port, this handpiece, which has got a nitinol ring, you have to give this laser. Can you see the laser being given now? You can see the bubbles coming. That's it. Once it stops, it'll give a reverse thing. And that's it. Once you do that, bring the handpiece out. You can see a reverse suction. And then you can see that is the capsule which is already. So you have a precision technique, but is it really required? In my opinion, with so much experience, it's not required. But if somebody has done just one cataract surgery, but they still have a load of 100 per month, probably, if it is cheaper, probably it can be done. This is a typical capsulorhexis, and this is what we have done. You can see after very long, it stays very nicely. It's a capsulorhexis which is automated, and we have published this looking at precision pulse capsulotomy. It can be used as an alternative, but it's a strong capsulorhexis as manual. It's good, but only thing is it's expensive. So that's the only thing. And in posterior lenticonus, these are the types of posterior lenticonus what you can have. You can use ultrasound B scan or even UBM or anterior segment OCT to see what is the depth of those. And we have done a study on this posterior lenticonus. Now we are looking at the phenotypic genotype correlation because posterior lenticonus does not have any systemic association. Very rarely they can be associated with anterior lenticonus. And with the intact capsule and with the capsular defect, there are two types of technique you need to use it. You can see the first video has intact capsule, but there is a crater kind of thing. You can see that already, but it's not broken. I implant a lens and then clean it up so that if I make a primary rhexis, it will become very large. So I implant the lens there and then I do it. In the second case, I aspirate from the periphery, and since that elliptical is smaller, we can still implant the lens in the bag in the second case. So even if you put implant in the sulcus with the optic capture, it's not bad. Again, my only instruction for everybody, especially newcomers, is be safe. Do a very safe surgery for these children. Otherwise, have you eaten with the tea biscuits? There is a time, right? If you cross that time, that's gone. Even in posterior lenticonus, this can happen. If you keep it too long, the timing is very important. If you keep it, we call it as chai is tea in Hindi. Biscuit in chai, sign, I call it as. So timing is everything in posterior lenticonus. So I have a video, and this is one of the publication. As you can see, 1 to 4% of our pediatric cataracts are posterior lenticonus. It's not very rare. When I was in UCLA, I've hardly seen cataract, maybe 10 or 12 cataracts in the whole year. It's very rare if you see a posterior lenticonus there, but I'm sure here there'll be a lot of posterior lenticonus. Sometimes the pupil may not be dilating. You have done everything and pupil does not want to dilate. This creates a lot of anxiety. Very much people are worried. You can use iris hooks. You can use intracameral epicane is available nowadays. It's very safe. You can use that. And if it does not, then you'll have to use the plug. This is a Kuglan hook, typical Kuglan hook what you have used, but it's important to use it. No need to become anxious. You can still give the outcome for these patients just doing this 1 or 2 or 3 or 4 Kuglan hooks. Sometimes you just use 3 of them. That's enough. And here, once you dilate it, you can look at the morphology. Sometimes I look at the morphology of the cataract intraoperatively, then I advise further investigations. Don't think investigation in terms of etiology stops after surgery. You can still order, hey, I'm looking at something different. I need to look at maybe anterior lenticonus. I need to get a renal profile. It looks like a Lowy syndrome. So you need to keep on thinking. That's why when you see a pediatric cataract surgery patient, at every visit ask, do they have any systemic association? Something new you didn't know. Sometimes a new syndrome you will be seeing for the first time. So again, the capsular rhexis and the whole surgery becomes different here. You can see a plaque there. Can you see? Behind this, there is a plaque. And again, for the capsular rhexis, you use the same technique, grip, grasp, regrasp, inward pull. Grip technique is always you have to use it. And then I always aspirate from periphery and then come to the center so that I'm safer. And once I do this, what's happening here? There is a plaque on the posterior capsule. Sometimes you can remove it. Sometimes you might have to do a vitrector for these things just to remove it. You can see I'm just almost done with the cortical aspiration. In this case, I am implanting the lens. When you are implanting, the leading haptic can push up so that you are not worried that it can go down. Otherwise, it can go down. So have a habit, inject and go up so that you are safe inside the bag. Once you have done that, you can beautifully remove this remaining plaque with the capsulorhexis, and you can vitrector, and you can remove this thing. And sometimes you see this kind of plaque. It's so thick, vitrector sometimes cannot cut it. So you can debulk it by doing a plaquectomy. So you can use this Sinskey hook. It just detaches. It's not a very adherent. With this you check and then inject viscoelastic and then aspirate it pull it very carefully. Don't at one go because you might remove the bag. It's coming, almost it's there, but the last part was still attached. That's the time I use some kind of scissor so that you can cut it. You can see it's coming almost, but you have to be very gentle. If you pull it, it can lead to zonular dialysis and many things can happen in this patient. So the last part, that part is not coming. So be careful. Just you can give one nick with the scissor, it'll come. So whole plaque can be removed. This part I am just cutting with the straight or a curved scissor you can use. You need to have small little instruments to make your surgery better. It's not very expensive. These are all small. And once it is cut, you can easily remove. This is a plaquectomy which can be done. And I don't know, Dr. Tazignan from Belgium, she gave some of these lenses. We are trying to manufacture this in India so that for the whole of Asia, we want to be a partner, but the discussion is on. I've used it in the 10 or 12 samples what she has given. It's a beautiful lens. It really works in some of these patients. And you can see this pentacam. You can see the lens is in place. It's beautiful lens. It works. This is after 1 year. I've taken this picture. So at this point of time, cost is the prohibitory thing for this particular thing. So just wanted to touch upon, when do you do IOL implantation in a kid? I do it. Age is not a criteria. Eye is a criteria for me. I don't consider age as a criteria. So everybody are okay till 7 months. Most of the people put them on probably aphakia. 7 to 12 probably, beyond 12 months, all of the people are comfortable in implanting a lens. I've looked at the complication rates of IAT studies. Finally, whoever had the second surgery is almost equal in both the things. You can see secondary IOL here and the intraocular lens group. And this is the difference what I have seen in terms of aphakia and IOL. Complications in their study was more. Expense is more in the first year if you want to implant a lens. Strabismus, glaucoma, and parent distress was more when you put an implant. That's the study summary, what I have seen. But we looked at our patients because the situation in our part is different. We looked at our long-term outcomes. It's reasonably safe in appropriately selected patients. Don't implant in every patient. That's why this is the decision making for an IOL implantation in infants. Biometry, ocular comorbidities, intraoperative findings, and surgical experience, I will put it. If you are done 2 surgeries in a kid and you want to implant, it's a different ball game. Probably you'll be safe by leaving the child aphakic. And this is what we have published, a Venn diagram looking at the preoperative factors, intraoperative factors, and socio-economic status. With all these considered, there is no one rule. You can change your decision based upon your location or your countries and your patient's kind of comfort, and provided you have the surgical experience. That's what I would do. And in our experience, in babies less than 6 months, we implant close to 50% of the patients. They get IOL, 50% don't get because they don't get the criteria fit there. More than 6 months, we put in most of the patient, close to 75%. I had some more tips on retinoblastoma and ROP. Probably I will skip that. I would like to show probably one case. In cases of PHPV, always do a good goniotomy. I think the preoperative assessment, including UBM, gonio, everything, we take almost 15 to 20 minutes per case because it's important. That's one opportunity you have. We also cauterize these vessels before doing the surgery. Retinal surgeons have endocautery. Go with the side port, cauterize that. You can see I'm trying to cauterize all the part there. You can see the long ciliary process from coming from there. So this needs to be cauterized, but I'm concentrating on these vessels. Otherwise, it will bleed. There is a font of blood vessels here. And once you have done, once you have one approach, in these patients, I will never put an implant because they have a very, very high chance of glaucoma. And even your lens can fall down because you can see the ciliary process is just connecting. You can see this is cauterized using the endocautery. Use this. The capsule also shrinks when you use this cautery. You can use on either sides. Use as many as you want because it does not really rise the temperature, not like even capsule laser. It does not increase the temperature intracamerally. So you can use it. It's an anterior chamber. And once you have cauterized everything, then you can start doing this. This needs a vitrector. Without that, it's impossible to remove this PHPV. You can see I'm trying to cauterize everything. Otherwise, you will have a huge vitreous hemorrhage intraoperatively and also postoperatively. I'm trying to find one plane here. I cannot with the vitrector. So that's why I went with the MVR blade. Now I got the plane. Now I'm using the scissor. That's why these small instruments are important for you. And you can give a nick. I try to cut it multiple pieces. And once you do that, then the vitrector, it can cut everything. So keep the cut rate slow and you can go all around. Keep a skirt of tissue around because if you cut everything, the ciliary process can go down and it might cause other problems. So that's the way you do it. And I just want to end with this one complication. If you are doing a surgery, you will have complication. If you don't have complication, you are not a surgeon. You are not operating. So I just wanted to see you all to see this complication and which happened, and I was lucky. If there is some music here, you can put it. Probably visco was there and the flow rate of your bimanual was too much, probably. And in front of your eyes, a normal case, you are about to close, just I'm done, just goes down. So be humble, always it can happen. It happened almost 6 months ago. So, but I was lucky, I did not. And the last slide, whenever you do, I think any one of you in this room can be doing a follow-up of pediatric cataract. Do a real follow-up, not half-half. Because I tell my fellows, They say real okay. Real okay means refraction and visual acuity checked. Amblyopia is ruled out. Over refraction, you have to do it. Eye pressure has been checked. You can have a clear visual axis if there is one eye esotropia that can go into amblyopia. Check alignment and rule out amblyopia. And here, look at all the lens related parameters, be it the opacity of the lens, centration of the lens, size of the pupil, shape of the pupil, everything. In pediatric cataract surgery, it becomes real. And if it is cornea, also same, you have to apply in a child. Cornea, everything you need to see. So do a real follow-up so that in the long term, you will have a good outcome. Thank you very much. I'll continue with the one more and the last talk. This is something easy. I hope it applies to all the ophthalmologists here, including retina surgeons, oculoplasty, everybody, because myopia is something everybody is excited about it. There are some treatment which has come in terms of treatment. I'm going to touch upon, probably I'll share 3-4 slides which are very important here, not everything. My question is, there is atropine, there is contact lenses, there is orthokeratology, there is peripheral refocus lenses. Which one to use it in which patient? You all know about these treatment options, but we have 4 myopia centers in our institute. We try to customize, create a customized approach to myopia. These are my disclosures. Maybe one of them, Essilor luxottica, is something related with the myopia. Otherwise, it's nothing. And I'm not going to talk about that lens. I'm going to talk about customized approach. When a child comes, whichever position, being a pediatric ophthalmologist, you should be able to do a refraction and you should be able to pick up whether it is an axial myopia or a non-axial myopia, because these treatments are only effective in axial myopia. Around the world, whichever it is, myopia is on the increasing. Maybe in some countries like US or Africa, it was less, but it's not as severe as Singapore. But if you look at this slide, it is increasing in percentage. Relatively, it is increasing everywhere in the world. But what is a comprehensive management? Some have a habit, hey, I'll use atropine in every patient because I am an ophthalmologist, it's easy for me. I am an optometrist, I will use glasses, opticals, it's easy for me. So they should not be profession-based or subspecialty based, or some places it's not available. If you ask here, do you have 0.05% of atropine? Not available, right? So it should not be. It should be based on evidence-based. What is the best evidence? And you need to prevent and identify high-risk children. And you want to see less and less patients who go into this category as much as possible from your efforts. And when you do a comprehensive approach, you have all of these options, right? Lifestyle is the most important. People talk about, atropine, forget about lifestyle. If you keep on giving, some of the parents say, I'm using atropine, but the child is looking at the screen for 6 hours. It does not really be effective. So these are all, again, I use this. Everything has an advantage, including light therapy and low dose atropine. But you need to know, where do you give what? I'm not going into the theory of peripheral refraction because I'll directly go into, we have made this simple instrument. People said, I don't have this open autorefractor to measure the peripheral refraction. We made this Spark, that's the last one. Our innovation team made that so that anybody in the world, that costs less than $20, anybody in the world, they can do peripheral refraction without using that, I don't know, it was around 20,000 US dollar, the open refractometer. So that's the open refractometer. that is from the Shin Nippon company. That's the only company makes it. So you don't have to use that. There is a simple one. You can use it. This is a peripheral refraction. We have validated it. We have compared with the open refraction. This is a publication. We looked at how the peripheral refraction component really compared to the open refraction. There is a very good agreement between the two, and we use this SPARC, simplified peripheral refraction using ancillary refraction component. This is just, can you see here? There is a reflector. In the road, you see a reflector. If I am seeing the reflector, on the nasal side, I am 22 degrees. On the temporal side, I am 22 degrees. There are 3 spots. Can you see here? There are 1, 2, 3. Just the patient will be looking straight, but you will be taking an angle. How do you make sure that it's 22 degrees? We have calibrated that into 22 degrees. So in terms of treatment, this is one of the important slides. I always go from base up model. Always measure refraction. Always do an ocular alignment, because if somebody has esophoria, the treatment is different. Always do an open refraction. Always take a family history. If both the parents are myopic, child having progressive myopia is much higher than if they are not. And also peripheral refraction and the refraction. First thing is lifestyle changes. This is the easiest and the simplest advice everybody can give. Next comes the atropine eye drops or the peripheral refraction glasses. If they have esophoria, I give bifocals, because you don't have to give any kind of this peripheral defocus lenses. And if they are older, you can give orthokeratology. If you look at all the parameters which can prevent the progression, orthokeratology has the highest success rate. But in the world, because of the limitation, we can't give orthokeratology for every child. And most important, I tell 2 things. Increase the sun time, decrease the screen time. So sun time, I know it's difficult in Middle East, because especially in summer, it's so difficult. And sometimes we can give a combination therapy like atropine drops, orthokeratology, and this. And always look for clues. This is the patient who has, what is this? It's typical microspherophakia. He has been put on anti-myopia treatment strategy. Always rule out. And she has this typical, microspherophakia with Weil-Marchesani syndrome. This is very, very typical feature of that. One of the things, give attention to axial length. Her axial length is 22. Look at her lens thickness, 434, 430. Anything beyond 3.75, it's thick lens. So people just don't look at it. You have to look at each of this detail. ROP, it does not work. You should not give. So in summary, identify the true axial myope, map the risk factors, pick up the progressive myopia, advise appropriate myopia control strategy, always counsel, because it's not going to be a 1 year thing. It's going to be a long-term thing, and taper and stop it very slowly. This is the impact myopia guidelines for myopia progression. We have made a consensus guidelines in our institute. Identify the true case of axial myopia. When you start treatment, if there is a more than 0.1 millimeter per year progression or 0.5 diopters progression, identify the potential risk factors. Look at the parental myopia. Ask them what is the screen time. Do a cover test. Do a peripheral refraction. Check lag of accommodation. If they have, this is the most important customization. If they have relative peripheral hyperopia, give defocus lenses. Maybe Halt or Stellest, whatever you are working with your hospital, or if they are older, orthokeratology. It can be given up to high myopia of -10. Beyond that, it's not possible. So peripheral refraction, your primary treatment should be peripheral defocus lenses. If they have high lag of accommodation when you check, because all these parameters, it takes less than 10 minutes to check. But many people think, hey, myopia, give glasses and send. But if you want to really provide a customized approach, you need to do these 4 things. High lag of accommodation, you can give bifocals. Even in near esophagia, you can see on the left side, you can give bifocals. But if there is no relative hyperopia, it's a pure axial, give low dose atropine, starting from 0.01% to 0.5%. So this is the most important customization what we use. And monitor the efficacy, and then look at start combination. Sometimes if it fails, one strategy fails, you start the second strategy after some time. And I always look at 2 years of stability, and more than 17 years, you have to, once you start, it's not going to be one time. And the last slide is, always remember 4 M's in myopia management. Master, basically understand the multifactorial nature of the myopia causation. There are X factors like estimate and quantify the myopia risk factor. Don't treat everyone with anti-myopia. There are some of them, just put them on natural thing, they will be fine. Monitoring is very important. Every 4 to 6 months, we need to call them. And the last thing, customize when you manage. Master, manage, measure, and monitor. This is one of the colleague who is working with me. He is an optometrist. I closely work with him. His name is Pawan Wakicharla. This is his slide. And that's what I just wanted to say about myopia. Thank you very much.
So trying to give a lecture after Ramesh is a challenge. Let's try to do it, and let's try to do it on time. I don't have financial interest in this lecture. I would like to start with the issue that be ready if you need to capture. But I would like to start with something that is called motivation, something that is called curiosity, something that is called a chat. How a simple chat in between can generate motivation, curiosity, and develop research questions. I'm going to give you some examples of this one. For example, inspiring people, where I've been chatting, Dr. Messler. He's concerned about the congenital glaucoma, the outcomes. We have discussions about it. What are we doing? So these concerns motivate me to do investigations, Richard. Dr. Jedan, with the fingers, can tell us how much is the pressure. This is so motivating. Dr. Awad, with few words, Dr. Twitter, Dr. X, primary congenital glaucoma is a corneal disease. Other people, Dr. Edwards, Deepak, how the sensitivity of the cornea is important in primary congenital glaucoma to be considered. But we have other people. All these people, they publish about the actual length and the congenital glaucoma. You can capture, if you want, the paper. It's a nice paper about this relation. Dr. Charhel, we spent 8 months writing a book to the Spanish Society of Ophthalmology. It's already published with the experience of cases about congenital glaucoma. So it's inspiring people. Ramesh has been talking about that one, the motivation. It's not about resources, it's about motivation. When I came here, I hate glaucoma. So look at this one, no? So congenital glaucoma goes beyond of the policies and procedures. We need to have these characteristics to understand and not just apply to congenital glaucoma, apply to many things. But these concepts, if you think small, you will be small. If you think big, you will be big. Keep this in your mind. You are invited to do it. IOP, glaucoma, fire, careful, everything is IOP, huge fire. Look at the relativity of the things. This fire could be a small fire. And we need to learn to evaluate the primary congenital glaucoma. And the IOP is just a variable. It has a value, has a weight, but it's not everything. Look at this patient. 2 years old. Would you operate this patient? You operate a CHED patient. Would you operate this patient? Was referred to Kekish. You operate a patient that had trauma for forceps in the delivery. So it's not the IOP. Primary congenital glaucoma goes beyond of this. And we have the tendency to be reductionism. Just IOP, the IOP is fine. Follow up in 6 months. It's the hallmark, but it's not everything. So my invitation is, let's try to do the zoom out and see how can we understand this one. Let's analyze some examples. Blepharospasm. How many times we ask to the family, has blepharospasm? Disappear the blepharospasm? It's a sign. Patient, when they improve the blepharospasm, disappear. What about the habestrias? We look for them, we measure, we check them. Dr. Ken Nisha, one of the founders of the WSPS with the doctor, they are operating the habestrias to treat the amblyopia. What about the sensitivity of the cornea? How many times we use CPC and we don't know if the affection of the cornea, or the patient is receiving medication, or the patient is having scars, and we never check the sensitivity of the cornea. So this is another variable that we could study and keep it in our mind when we use many methods of measuring, but we could overestimate, we could underestimate. Each method has advantage, disadvantage. There are many stories about the biomechanical changes in the cornea. We can move to the eyelid. So all these variables regarding the measurement, we need to record it, we need to know it, we need to study, we need to analyze it, because probably we're not recording correctly the parameter that we want, and we are talking about intraocular pressure. These parameters, you can keep it as normal parameters when we evaluate patients. Parameters about the corneal thickness. Thickness of the cornea is a value that is going to affect our outcomes, our evaluation. Copy this formula. I create this formula based in this paper. I took the data, and based on that, I built a function, mathematical function, and this is the adjusted IOP. We have to use it. Patient has 30 in the eye care, and Dr. Jedana says, no, this is 20, this is 15. Who's right? Probably he's right. So copy this formula. That's the QR code, take it. It's not precise, has limitations. It's not adjusted by gender, it's not adjusted by age, but it's a value that is going to help us to have more detail about this one. You can go, this is the way that appears, it's in Excel, you put the value that is, you measure it, the pachymetry, and it's give you the value that the probably IOP. That's important. Keep it with you, it's for your use. It's going to help you to have an idea where we are regarding the IOP value. We measure the corneal diameter. How many times we measure? Dr. Baji was telling me that now she's measuring white to white distance that is different, the cornea with the caliper. Well, this is something that we need to analyze. After surgery, the cornea can decrease the diameter. And sometimes we don't pay attention to that. We don't take this variable as that's important. Other one, the axial length. How important this one? This is the paper of Dr. Ibrahim, our people, Rizwan, about this one. Axial length, how the axial length change, how the axial length, and it's not a linear relation. It's a polynomial relation. Based in the paper of Rizwan and Ibrahim Oweda, I built this temporary formula that can help you to estimate the axial length according to the age of the patient. It's not adjusted by age, by gender. I'm finishing, and probably this is going to be a paper. Okay, we're working on that, but this temporary can help you to say, well, this axial length is in patient with glaucoma. So how far away I am from the patient with glaucoma in axial length in a specific situation? Take it. I'm not saying that it's precise, has defects, but can help us, can give us an idea about the management. Continuing with this one, this is the formula. The formula is built in years, so you put 1.7 years, and it's going to give you the estimated, but for a patient with primary congenital glaucoma, estimated age. It's going to help us. It's going to give us a parameter to compare. UVM, we underuse it. Angle open or closed. No, this is not the UVM. Look at this one. This is the Schlem. Can you imagine if you see the Schlem, you could do deep sclerectomy. You can change your approach therapeutic because you have the Schlem. How many times we say, no, it's a secondary glaucoma, we cannot do deep sclerectomy. Why not? You have a Schlem. You have 360 degrees of Schlem. We can measure the thickness iris, we measure the angle, we can measure many things, the spherophakia, as Ramesh mentioned. So, guidelines. We create these guidelines, you can copy. Probably they are long guidelines about primary congenital glaucoma, but I invite you that you get it, read it, because you're going to help us to widen our vision and do the things better than actually we're doing. Now, let's change our vision as a clinicians, and let's think as a data analyst and talk about variables. All these things that I'm going mentioning have some variables. And we're going to give a weight to these variables. Let's suppose diagnosis, management, outcomes, prognosis with these variables. Just do this, look at this graph. It's in the cornea, and look at the parameters, diagnosis, management, outcome, and prognosis. So, having these issues, I'm going to mention some of these variables that we are going to study. IOP, remember, look at the amount of variables that we are going to create. Look at these ones. Well, probably many times we don't ask them. We grab it and we put it in a table. Okay, let's keep going. How many times we ask all these details about the cornea? We are wrong. IUP to 35. See you in 4 months. You see? Just cornea. I documented. Keep going. Anterior chamber, angle, iris. I collect these variables. We talk about them, but probably we don't document it. So I grab it, and I'm going to document it. Look at, we have 3 columns now, but we can keep going. Ciliary processes, sonula, lens, ciliary body, findings that we see often, but we don't pay attention. So just grab these ones, and we document it. We keep going. We keep going with the vitreous, with the sclera, with the choroid, with the retina, with the optic nerve, and we document it. Here, sometimes we put copying. Wow, copying, 0.8, 0.6, that's it. So we document it. Keep going. The refraction, the axial length, the keratometry, the visual acuity, change, not change, increase, decrease, and also I document it. From IUP until now, we have almost 81 new variables, if we think as a data analyst. What I'm going to do with this? We change our mind now. Clear. Here, IOP has more weight, but we have 81 new variables, okay? I use AI. I put it this table. I told the AI, please generate me a scoring system with these variables based in literature review. I spent 3 months doing literature review to get the variables and I put it in the AI system, in an AI application. And it creates this one. This can be adjusted, they can be changed. I'm not saying that this is the truth, but give me something interesting about this one. So I add the UVM. Look at this one. It creates a score, and when you go to zoom in, you can take the Excel sheet. You just need to do click, 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 click. That is facilitate your life. I mean, you don't need to write to avoid the typos, and give me a score. I'm not saying also this is the final score. It's something that we can discuss and we can work on that. But we have this one. With these variables, with these 81 variables, now we can do something different. We are gonna use the AI, no? And look at what I did here in Cakes. I captured the scoring table, progress node, operating node, DID, avoid the identification data, and based on these notes that we write in the track care and the progress node and the surgical notes, I copy and I send it to AI. Today we have AI that can work in the cloud, but we have AI that can work locally. So I grab this file, that is a picture that took me 5 seconds to do this one, put it in the AI, and look at the result. She retrieved me, according to this score, in this patient, this summary, automatically. According to this table, retrieve me this one, the age. So where are we going with this? Then I ask, please give me a score about this patient. I write it, give me a score. And gave me a score. Just check what is happening. So the score of the patient was 8 points. And according to this, the patient has a mild glaucoma. So, but it's not true. We under scoring this patient because we didn't input all the information necessary for this. So the score was low, not because the patient is mild, the patient is different. So I feel it, I don't know, I add the corneal, so the score raised. What is the message? The message is that we need to document this information, document it well. It's easy to document it, it's fast to do it, it's just clicks. And this is going to allow us to have a better way to evaluate the patients with glaucoma that goes beyond of the IOP and the copy. No, this is the main concept. And with the aid of the AI, so we can do this easily. So I say, please write the progress note. Look at the progress note. We were fighting these days in the hospital. No, progress notes, yes, progress notes, no. Automatically done. Automatically. With real data. Just saying, write this one. And also, this you can say, well, I don't like this style. It's too long or whatever. So I could switch, no? And say, give me another summary. You have this one. What about our notes in the track care like this? This is an opinion. But one of the most important part of this issue is that if we use this approach that is using these variables, using the AI, we also can send this information, no, to the insurance companies, for example. So in summary, clean and immediate data, better approach, reduce the number of clicks, reduce the typing time, increase the time with the patient, and can be applicable to the insurance company. That is something that we were discussing as a staff. So this is a way that we can solve some issues that we face as a hospital. So think about this one. And as a conclusion, thank you very much. I'm not going to ask myself, So question for Ramesh regarding the myopia and cataract. Any question?
Thank you, Dr. Ramesh, again for the very nice lecture as regarding pediatric cataract. Um, regarding the esotropia, which only happens after doing the cataract surgery, regardless the patient is unilateral cataract or bilateral cataract surgery. In some patients who have who have esotropia before doing cataract surgery, like a small angle, 10 to 15% diopters of esotropia. After surgery, it gets more, up to 30 to 35, and we have to explain to the parents. My question, what is the exact etiology of this one? Or, uh, for example, like the amblyopia or something, which was there beforehand, it was only after doing the cataract surgery, and how to manage, for example, how many months we have to wait after giving the full refraction before going for PMR.
Yeah.
Thank you.
I think it's an important issue which we don't talk in usual cataract surgery talks. 30 to 60% of the pediatric cataract surgeries will have some kind of strabismus. If they have something before, the etiology is clear. Probably they had a difference in the vision in both eyes, or they had some nystagmus, or convergence dampening could be the reason. But if it happens after surgery, it could be related to poor vision in one eye because one of the cataract was denser compared to the other eye. And it can be because of the sensory deprivation in unilateral cataract. And third thing, it's because of the accommodative effort is gone. They don't have the fusional ability. That's why they develop strabismus. Now, how long you wait? I wait at least 8 months to 1 year before I really do it. Number one, I start them with patching and probably give appropriate glasses. And number three, the surgical doses becomes less in post-cataract surgery patients. If I have 40 prism diopters of esotropia, generally I'll do 5 or 5.5. But here, because the accommodation thing, you need to do less, otherwise you will develop a consecutive exotropia. So in terms of waiting, I'll wait around 8 months before I intervene in this patient. Don't jump into surgery very fast in these patients.
Yes, I heard you said in PHPV you don't implant an IOL. So is it like
I don't implant in that case. It's not that I never implant, because persistent fetal vasculature has many forms. It has got anterior form, posterior form. Anterior can be just a plaque-like cataract and things like that. I was mentioning in that case, I will not. But otherwise, I do implantation if they don't have a severe microcornea, because PFE always comes with microcornea. But if they don't, I will implant.
Implant in the sulcus.
In the sulcus or sometimes in the back. Yeah.
One question, 6 months of age, what is the power of the IOLs, and you find it in the market?
We get up till 36 diopters. Sometimes even 40 can be bought for us. But I undercorrect around 8 to 9 diopters in them, or I undercorrect around 30%.
Okay. Well, thank you very much for your participation. Thank you, Dr. Ramesh.
Thank
It's
you
been
very
an honor
much.
to have you.
Thank you.
And you have a question? I know Dr. Mesfer has a question.
What is the timing for surgery for healthy born baby with bilateral congenital cataract? In our institution, we do it between 4 and 6 up to 10 weeks after delivery. For premature, we look at the corrected age and accordingly we do it. But we didn't put patient who less than 3 kg for surgery.
Yeah. I used to be. Everyone in the world used to be very early surgeries. Now people have relaxed. In a unilateral case, we can wait up till 5 to 6 weeks of age. In bilateral, as you said, we can safely wait for 8 weeks to 10 weeks. We don't have to rush. I have to do the surgery in 1 month. Not required. And as we are talking, I am looking at a data of 700 patients where by default to our institute, bilateral cataract has come at 2 months, 1 month, 4 months, 6 months. I am looking at an outcome. But when I eyeball the data, either it is 1 month or 2 months, the difference in the visual acuity is not too much. So I would safely wait up till 8 weeks, maybe sometimes 10 weeks. Without prematurity, without 6 to 8 weeks, I'm fine to wait. From birth to 6 to 8 weeks, yes.
And when you did the surgery for the severe form of anterior persistent fetal vasculature, you were able to dissect all the plaque within the center, but at the same time, you get the remnant attached to the ciliary process. Based on my estimation that this fibrotic, it may constrict with time and cause ciliary body detachment. For the reason, when I do it, or my colleague to do it, we go with venous or scissor and snip it, make it relax.
Yeah. This is most of the patients I do it. But when there is a 360-degree attachment of the ciliary process, if I detach, the direction of the ciliary process goes back, and we have seen some of the glaucoma patients coming. But I agree with you. In most of the patients, I remove everything. But again, this was an exception. I kept the skirt of that thing. It's not a very tiny opening. I made it as big as possible. The last part, I kept it. Because once it falls down, they have a high chance of glaucoma.
What I noticed when there is a severe form of PHPV and the ciliary processes is under some tension, you will find that the cornea curvature also is affected. The carrying is not normal, steep cornea.
Yeah, it's possible.
And once we did the dissection of all this persistent fetal vasculature and tried to relax all the ciliary process and ciliary body,
the tension became
the cornea
less.
will take another shape, and body ciliary body will go back near to the sclera rather than to detach in the future.
Okay.
About the myopia and the behavioral changes. Does screen sunlight and screen time, decreasing them, will decrease the chance of developing myopia or progression, or both?
Mostly it's the development of myopia. Once it develops, it does not help much, but there is no definite answer that it completely doesn't help. It can still help a little bit.
So still advice for both?
Yes. It's just, from a point of prevention, it's still better to continue.
Thank you very much.
Yeah.
I just want to share my experience in cases of PFV. I used the focal plate to cut across this very thick membrane. It's really very easy and very fast, like cutting in a cheese. It's really marvelous.
Okay, Fugo blade. I think I've heard from some other people. It's good. I don't have any personal experience with that. Yeah.
So let's continue with the seminario. Now we will be enjoying Dr. Abdulaziz Awad. You have better voice than mine, no? We'll be talking about the large segment superior oblique tendon expanders in the management of the severe Brown syndrome. Dr. Awad, please join us.
Assalamu alaikum. Good afternoon, everybody. It's certainly a humbling experience to talk after Professor Ramesh. However, I will try. The good thing that he didn't talk about Brown syndrome. Very briefly, I will talk to you about a severe form of Brown syndrome. Nowadays, and strabismologist knows, there is even speculation if we should ever, operate on Brown syndrome. However, those are mild ones. The ones I will talk to you, you would hopefully agree with me that they really do need surgery. And I'll talk about a specific procedure, the use of silicone expanders in the management of those severe Brown syndrome. As a background, Dr. Brown described the syndrome in the 1950s. It's a very interesting story where he observed, a couple of patients, presented them at APOS, and nobody knew what is it. Next year, he came back and he, in addition to his presentation, he confirmed to the group that he did a forced duction, brought those patients to the OR, and he found them to be really restricted in elevation, in aid deduction. And then was suggested that a superior oblique tenectomy is the way to go. Unfortunately, that has resulted in significant iatrogenic superior oblique pulses. As you can see, the prevalence ranged from 78 to 82%, quite a significant one, which has, provoked the pediatric ophthalmologists to do combined procedure, a superior oblique tenectomy with an inferior oblique weakening procedure at the same time. And then, Dr. Wright in the 1989 proposed the silicone expander, which I liked, and consequently I used. Just let's agree on the definition. When we say severe Brown syndrome, what do we mean? When we say severe Brown syndrome, we're talking about a vertical deviation in primary position. People present you with a vertical deviation in the primary position, a downshoot in aid deduction, and definitely, a limitation of elevation in aid deduction. And when we say a moderate Brown, no vertical deviation in primary position, however, they have a downshoot in aid deduction. And when we say mild Brown, we mean no vertical deviation in primary position, no vertical deviation in any horizontal gaze. However, there is the limitation of elevation in aid deduction. All the ones I will talk to you about are the severe ones where they have a primary position, significant vertical deviation. You will see soon. I'm reporting to you 12 patients, 12 consecutive patients, whom we have evaluated here at KKH, severe Brown syndrome, with a significant hypotropia in primary position, more than 20 prism diopters, with a minimum follow-up of 12 months, 8 males and 4 females at age, at surgery varied from 3 to 22 years of age. Abnormal head position was seen in only 2 patients. This is really mostly due to the severity of the vertical deviation in the primary position. Hypotropia ranged between 20 and 40 prism diopters, and all were constant congenital Brown syndrome, and during the surgery, all of them had a very short tendon that I had to really manage. Postoperative overreaction was evaluated at 3 and 6 and 12 and 24 months when available. I have used in all the patients the right technique, and I will show you photos of that, where we approach the superior oblique through a temporal, superior temporal fornix incision. And after hooking the superior rectus, I go and I look for the superior oblique tendon, identify it, open what I call a sheet. If you agree with me or disagree, just tenons over there, and severe it and suture a large segment of 240 silicone bands of 10 to 12 millimeter. I can say with confidence I've used even 12 millimeter silicone bands. I have left 3 millimeters from the nasal border of the superior rectus, mainly to avoid any adhesions between the expander and the superior rectus muscle. I've used 5-O-mersaline because it was the only one available. For me at that time, cortex was not available, and I always care to close the intermuscular septum. The postoperative follow-ups, a mean of 38 months, quite a good number, range between 12 and 52 months. I've graded my outcome into excellent, good, and fair. Excellent if they had some elevation in aid deduction, 25%, and a good one if they had a +2 restriction of elevation in aid deduction. All of them, they have resolved their primary position hypertropia, and a fair outcome if they had a +3 restriction of elevation in aid deduction, and that was in 25% of the patients. Undercorrection was seen in 75% of the 12 eyes at 6 weeks. However, significant improvement was noted with longer follow-up. So, don't feel really disappointed in your first or second post-op if the patient has still some vertical deviation. It certainly is going to be improved. The Brown has improved in almost all of them. None of them required further surgery, and the postoperative hyperphoria was noted in 3 patients. No extrusions of the implants was noted. The advantages of spacers is, as in my mind, is a low incidence of overcorrection. As you have seen in the old days when they did the tenectomy or tenotomy, significant number of patients with time, they ended up with an overcorrection that might need further surgery, and have, suggested that people do a simultaneous inferior oblique muscle surgery during the tenotomy. It's a one muscle procedure and offers variable weakening length according to your choice and, probably your intraoperative force reduction test. The disadvantages is an initial undercorrection. As you've seen, 75% of the patients, they had an undercorrection in the initial phase, and possible extrusion, which fortunately we didn't have. A down gaze restriction, especially if you didn't care to maintain the relationship between the superior oblique and the superior rectus. As you've seen me, I always taking care to leave 3 millimeters between the two and not to violate the relationship between the tendon and the superior oblique. I try to maintain that relationship very well. Possible residual Brown, which we fortunately didn't have. That's how I do it. After hooking the superior rectus, I go back, blunt dissection with a retractor. I wish I had your retractor, Dr. Ramesh, but I use a DMARS here until I find this glistening structure, which is the superior oblique tendon. I go over it directly and open the tendons or intermuscular septum and hook the superior oblique under direct vision. Very important and very critical is to hook the full muscle. Frequent force reduction at the time of surgery is the key to make sure that you have hooked the full tendon. Then, once identified and opened and hooked between 2 muscle hooks, I take sutures at each end of the tendon, and I sew the after taking the sutures, I separate them and I suture the silicone band in place, and then I close the intermuscular septum. Few pictures of my patients: an isotropic Brown with vertical deviation of 30 prism diopters, primary position, and here he is, like a week after surgery, where he is really like, his vertical deviation has significantly decreased or even disappeared. His pre-op pictures, where we can see the limitation of elevation in adduction, and this is him post-op, like few months after the surgery, and his 9 positions where you can see the significant improvement even in the elevation and adduction. Another one with the 40 prism diopters of hypotropia pre-op, and you can see the in fact the downshoot in adduction in addition to the limitation of elevation in adduction. Like a month after surgery, she's orthophoric, and yet she doesn't elevate very well in adduction, and she maintained this. Thank you very much, and it's really a great honor and pleasure to have Ramesh here.
Thank you very much, Dr. Awad, for your presentation. He has a wonderful video about how he do the procedure that is very delicate, very
I wish.
pure
I don't.
and so I observed something in you in one of the
Yep.
steps of the surgery that you, when you were working with the superior oblique, I would like to first one question: nasal or temporal approach to this procedure? Second, you remove the eyelid speculum to
Yes,
approach
exactly.
the. So can you enlighten us about this, because we have residents and fellows?
I
yes,
do both. I do nasal and temporal. However, I prefer the temporal, honestly, as per Dr. Wright description. I go on the temporal side of the superior rectus, and I make a fornix incision, hook the superior rectus. Then at this point, I remove the speculum, and I put the DMR structure to give me much freedom to access further part backwards to reach the supraoblique tendon. And then, once identified, I make sure that I make a small opening into the muscular septum and hook the muscle and hook the tendon well. That's the key, really. If any fibers remains, it would not work. The procedure would not work.
Thank you. Regarding when we compare the silicone band expander with the chicken suture, you perform both. Any comments or any suggestions regarding?
Maybe we can hear from Ramesh. Do you do the expander or the? Yeah.
I use the same technique coming from the temporal area, but I have switched over to other technique, either expanding the length of the muscle,
Z tenotomy,
or sometimes Z.
Yep.
Sometimes I use complete tenectomy because, as you said, you have put mild, moderate, and severe.
Yep.
Sometimes there are Brown syndrome which are very, very, very severe, especially after some kind of fibrosis. So there I do a Z tenotomy because I have given up on this because over a period of time it causes a little bit of scarring. I used to do it maybe 1 decade ago or so, but now in my hands, either a Z or lengthening of the muscle really works. And in the worst case, I do a chicken suture.
Yeah.
So chicken suture leads less fibrosis and less scarring there.
What suture do you use?
It's a non-absorbable suture. Generally, I use a Dacron suture.
Dacron.
Yeah.
I'm sorry, that question. You use a green suture in the is Dacron suture?
Dacron, yes.
Interesting. Dr. Mesfer is a pro chicken sutures when we talk about Brown, and we have discussions in the CTR about the possibility to develop foreign bodies, reaction. So do you have any comment, Dr. Mesfer?
I didn't like to put any implant. But it was very popular, as mentioned by Dr. Ramesh before. It was very popularized and a lot of articles. But I found just once you control the capsule and retain the capsule around the tendon, you didn't need to do more than just tenotomy. I find it's rarely I have to go for the inferior oblique and do for oblique myectomy. And I do it rarely. I didn't have much experience with it, but I prefer not to put any implant in the office.
Regarding, let's suppose this is a scenario, and this is for Dr. Awad and for the audience. In the scenario that you are doing superior oblique surgery, you find orbital fat. Any comments regarding this finding during the procedure? Ramesh?
So if you go from the temporal, I think finding the fat is very unlikely. Sometimes there are many people in the world, they do something called massaging of the muscle. They do a repeated traction test, and if there is any kind of cyst or anything, it just ruptures. Only thing I do is I look at the whole length of the tendon. I start from temporal because that's the easiest way. Without any trauma, you can isolate the muscle.
Yeah.
But once I isolate, in Brown syndrome, especially the severe one, I go along the trochlea and see. Sometimes you can see that some kind of cyst there, you can detach it. And even to shave the superior oblique muscle, this area, it becomes, because it's nothing to do with the fan insertion, because superior oblique has a fan portion and a cord portion. But mainly the problem is there in the cord portion.
Absolutely.
So
yeah. The
I
tendon
would,
and the
but
trochlea.
I rarely find any kind of fat in this kind of patients unless you really go very deep into the orbit.
Dr. Shamrani?
Thank you, Dr. Awad, for the nice presentation.
Thank you.
I just concur with the idea of don't rush to see the outcome of your surgery.
Thank you.
Sometimes the first post-op visit, you see patient has nothing done. And then after a while, you see the improvement, almost recovery the condition. And the importance of repeating the force reduction test after cutting the tendon to make sure there is no residual fiber. Have question, is it always correlated the degree of the restriction and force reduction test to the clinical presentation? Have a patient who's having severe head posture and typical picture of Brown in clinical orthotic ORCAP. Interrupt, the amount of restriction is not as much as expected from the clinical presentation. So it's always correlated, the clinical presentation, to the degree of the restriction?
You know, I'm going to really like to talk of the top of my head and really look forward to hear from Ramesh. In those ones, honestly speaking, I look for a medical reason for the Brown syndrome because it could actually be very variable, like a sinusitis, a medical condition, you know, like a rheumatoid or something like that. That's what gives, you know, the variability between the restriction and the clinical presentation. That would be my answer. Ramesh?
Yeah, usually I don't think so. There is a typical correlation. In medical cases, because it's acquired, they come up with the abnormal head posture. They avoid the adducted position.
Yeah.
But in patients with the congenital, sometimes I've seen, I don't know how many of you image the orbit for Browns. Sometimes we do. That time you see a very small superior oblique on the side of the Brown syndrome.
Oh.
So this is where we try to correlate, but when you do a traction test, it's not so tight. And in these patients, already in the literature, there are a lot of publications. It's one of the congenital cranial denervation syndrome. So in these cases, I will not do a superior oblique tenotomy. I'll do inferior rectus resection.
Oh, nice.
So there are I had some cases to share probably sometime.
Yeah.
So that's where I do an inferior rectus recession in spite of being it's a Brown syndrome. There are very, very rare cases like that.
The elongation, and post-op still have the head posture, although follow-up like 6 months still it's not improved much.
One more thing I just wanted to say is sometimes people leave the tendon a little bit behind. As you said, use the Demers retractor or whatever it is. You have to hook the whole muscle.
Yeah.
If you leave it, little bit can
the same,
lead to repeat it.
Yep.
And force reduction is very important. Yes.
One thing I would like the audience to know is the neuroimaging that you have shown for nystagmus. Looks very similar to Joe Demer's, you know, coils. Do you have a similar setup?
Yeah, we do have a very similar setup because we closely work with the MRI and we have a quasi-coronal cuts for every patient. We try to get it. There is a protocol. Already we use it.
I wish we can share with us.
Yes, sure.
Thanks a lot.
Any other question from the audience?
Thank you very much.
Sorry, one question here.
Thank you, Dr. for the latest lecture. If we have a patient with Brown syndrome and we're planning to do, for example, superior oblique waking procedure, and intraoperatively, while we're doing the force reduction test, at first we encountered some restriction, and then it went off. Will we still go for weakening procedure of the superior oblique, or we can consider?
Just answered by Dr. Ramesh, where he said the massage of the tendon. Probably those are one of those patients. If it gets resolved, it means that you've really done the trick. Probably you don't need to do the surgery.
Thank you very much. Thank you, Dr.
Thanks.
Awad.
Thank you very much.
Dr. Huda.
Thank you, Dr. Sesma, Dr. Awad. Thank you, Dr. Ramesh, for nice presentation. I'll be calling Dr. Saleh Misr, Dr. Professor Ramesh to the stage. Dr. Sesma, please.